So I'm going to start with smoking cessation. Dr. Trivedi briefly mentioned it in Dr. Best Marcus's work. Numerous studies have shown to be somewhat efficacious in exercise smoking cessation. One of the first major ones was Dr. Marcus's study in 1997, Commit to Quit 1. And they looked at exercise in addition to CBT. Now, this was done in an ideal controlled situation, in a hospital, in a perfectly controlled situation. It was a 12-week program of vigorous intensity exercise, but they had a kind of run-in period, whereas they didn't start the exercise intervention until the last 3 weeks of the smoking cessation program. So there's a long run-in period of their doing the smoking treatment and then going into the exercise intervention. They did their study 60-85% of the Cravonin formula using the max heart rate from I think it was a cycloergometer test. And interestingly, at this time, they allowed the participants to exercise on pretty much any type of aerobic equipment as long as 50% was done on a stationary bike. So you had a wide range of modalities in this study. A few years later, she followed this up with a Commit to Quit 2 study. Again, a large number of female smokers. And again, exercise or equal contact added on to CBT. However, what was different in this one is they wanted to do this in a less ideal situation. It was done more in a community setting. So in this time, they only did 1 time per week in their study gym. They also reduced the length of the study from 12 weeks to 8 weeks being the minimum amount of time they needed to do the CBT training, and there was no run-in period. I also found interesting looking through the study that this is one of the few studies in these large-scale public health type of studies using exercise that they validated it with or verified the home-based exercise using accelerometers. This one, they also dropped down to moderate intensity exercise. In the ideal setting before, there was vigorous. So they said, well, let's see if moderate, because moderate is maybe something that we can do more on our own at the home-based setting. And the dose, as in Commit to Quit 1, was a time volume per week. So they're aiming for 165 minutes per week, approximately, over their 5 sessions. And then some of the studies with exercise interventions, depression, most of them done with Dr. Trivedi. This one is in combination with Dr. Dunn. It was done at the Cooper Institute. They randomized individuals. They had 2 questions in this study. One was dose. They looked at a lower dose of 7 kilocalories per week, and kilocalories per week is the number of kilocalories per kilogram or body weight that's going to be completed each week. So they looked at 7 and 17.5. At this time, 17.5, that translates to about 210 minutes of moderate intensity physical activity. The recommendations at this point were most days of the week, so that'd be 30 minutes a day times 7, that'd give you your 210. And they also looked to see if frequency had an effect. It didn't matter if it was 3 days a week or 5 times a week. They exercised treadmill or stationary bike, and then did a follow-up continuation phase of 12 weeks. In this one, he was talking about control groups. They tried to exercise placebo control group. This one was they were doing stretching or yoga or just some type of easy movement, but not moderate or vigorous intensity exercise. The results from this, when they looked at frequency, they saw a decrease in HAM-D scores amongst all groups, but there was no significant changes between or differences between the groups. So the frequency they determined didn't really matter. But when they looked at the dose, they saw that while all groups showed improvement from baseline scores, the public health dose of 17.5 kkWs was more efficacious. So that's kind of leading us towards this line of a greater dose. Now, I think Tracy is going to present some data next that might disagree with this, but at least at this point, that was the thought. This is followed up with another study that Dr. Trivedi did out of the Cooper Institute again in Dallas, looking at depression again. This one, they wanted to look at whether a low dose of 4 kilocalories or a high dose of 16 would make a difference. And just, again, similar type of setup as you're seeing here, 12 weeks of more controlled, supervised exercise. But still, even during that time period, they're only doing 1 time per week, and the other 2 times are on their own. And then the follow-up, they're doing an additional 12 weeks of home-based exercise on their own. They did, in this one again, they have a choice of treadmills or cycle ergometers, so you're starting to see a more controlled environment for the calculation of caloric expenditure, and they did their max test on cycle ergometers. And I think that looking at some of these studies, that's something to consider, that they're testing people, getting a max heart rate on a cycle ergometer, and then doing a prescription for a treadmill off of that heart rate. And I think there's a little bit of a issue doing that. They did not capture intensity. The participants were allowed to exercise at whatever intensity they felt would suit them the best. And they just monitored this through the heart rate, Finally, the last two studies I'm going to look at are more focused in chronic disease, done with Dr. Tim Church and Stephen Blair. First one was done, again, at the Cooper Institute. This is Dr. Church's study in FLAME, looking at C-reactive protein. The results were just recently published. They did a 6-week run-in period. Again, they were able to test the participants' desire to be in the study, because once you randomize them, you have to analyze them. So they really tested them, see if they wanted to be in the study, and then they engaged them in 16 weeks of the intervention. And this maximal test again was on a cycle ergometer, and then the heart rate intensity was 60-80% of the VO2 max. They, again, 16 KKWs, so we're seeing this similar 16 or 17.5 dose per week over 3 to 5 sessions. Now you're seeing a forced modality between cycle and treadmill. They thought, their thought going into it was that the treadmill would create more injury situations. They said, well, we'll exercise on treadmill because usually it's more acceptable to the participants, but then we'll cycle them off onto a cycle ergometer the next session, and hopefully that'll prevent injury. They did allow a makeup or a carryover of dose, so if I happen to miss one of my laboratory sessions, we would give you a heart rate monitor, and you could do it on your own the weekend and bring the data back to us. So these things I'm going to relate them all to how our study as we go along here. Final study just came out in JAMA. Dr. Church is now out of Pennington down in Baton Rouge. Looking at type 2 diabetics, they had a whole bunch of different groups here, but we're just going to focus on the aerobic condition for now. It's a 9-month intervention. They had these individuals come into the lab, all supervised sessions, nothing at home, all supervised for 9 months. Now they've switched. They've gone max testing on the treadmill, and all the sessions are done on the treadmill. So they're matching the max test with the intervention, and they're doing 12 KKWs. 12 KKWs is approximately 150 minutes per week, which now meets or matches our current guidelines, for physical activity recommendations. They're doing 50 to 80% of maximal oxygen consumption, so this is now in the range of moderate to vigorous, depending on how hard a participant works.